All right, so let's get started. Thank you everyone for joining us today. Today we are going to get started with our learning collaborative on addressing barriers to colorectal cancer screening. And this is brought to you by the National Center for Health and Public Housing, also in collaboration with the American Cancer Society. For today's session, we will be going over colorectal cancer screening recommendations. Before we continue, the mission of the National Center for Health and Public Housing is to strengthen the capacity of public housing primary care grantees and other health centers by providing a range of training and technical assistance. NCHPH is also a project supported by the Health Resources and Services Administration and is a national training and technical assistance partner that is 100% financed by this grant. And the information presented today are those of the author only. Here we have a few housekeeping items. This is just a reminder to all that all participants are muted upon entry. Please make sure that you engage in the chat or verbally. Please also raise your hand if you would like your line to be unmuted. And this meeting is also being recorded. The slides and the recording link will be sent to you all via email after today's session. And today, we're hoping that it will be a very engagement session. So please make sure that you engage in the chat again. And if you would like your line to be unmuted, we will be doing that as well. This is also another announcement to please complete our post-evaluation survey at the end of the session. NCHPH is also providing certificates of completion for attending all 4 sessions that are part of this learning collaborative. So please let us know in the question that we have provided in the post-evaluation survey if you would like to obtain a certificate. So this is some introduction about our NCHPH staff members. My name is Fide Pineda Sandoval, and I am the TTA manager here at NCHPH. And I will be helping facilitate the session. We also have Dr. Jose Leon, who is our Chief Medical Officer, who will also be helping us in facilitating the session today. And we have our guest speaker from the American Cancer Society, Molly Black, who is the National Director of Cancer Screening. And now I'll pass it on to you, Molly.
Wonderful. Okay, well, always the first test is, can I share the slides? And well, I guess the first test is you can hear me, but I see heads nodding, so that's wonderful. I see a few familiar names in the participant list, which is wonderful. Hopefully you'll stay on since you've probably already heard this spiel before. If you all would put which health system you're calling in from, what's your FQ? Let us know in the chat. And while you're doing that, so today's objectives are time together. I'm hoping that you all will leave with, being able to explain the benefits of colorectal cancer screening to anyone who will listen to you, to describe the screening guidelines, to identify those kind of critical components for guideline activation, and to summarize some of the screening trends, and also to choose strategies from this webinar and from your peers that you want to, put into practice to increase your own screening rates and access to screening. Wonderful. Coast to coast and in between. Fantastic. Okay, so now some additional interaction. Thanks for interacting in the chat. Annotate. So now put a dot or a star, and the way you do that is on your bar. It might be, you might have to click the 3 dots for more, but there'll be a little pencil. And this is saying I got an upgraded toolbar for Zoom, and you can put a dot where you're coming from. I'm just going to color in a little bit. Ooh, good. I see some dots. I'm beaming in from the mountains of Asheville, North Carolina. Love it. Okay. Thank you all. And I'm going to clear everybody's drawings so we can move on to the next slide. Oh, wrong way. Okay.
I can't imagine any tomorrow without you in it. So today I say, I love you. Get screened. Regular cancer screening saves lives. Visit cancer.org/getscreened to learn more.
Awesome. So now another interaction. We have a poll for you. Do you have someone in your life, personal or professional, that needs to be screened for colorectal cancer? I know professionally you do because I've seen your screening rates. Yes. Yeah, you can put it in the chat or vote in the poll that hopefully is popping up for people. Yes, this is one of those, if we were all in the room together and we stood up, everyone would be standing. And so hopefully by the end of the Learning Collaborative, you all have some extra tools in your toolbox to get all of these individuals who are unscreened and not up to date with colorectal cancer screening up to date. And it's just so imperative. This is some of with the latest data from the American Cancer Society's, one of my favorite publications, our annual cancer facts and figures. And so, you know, the rates have been going up for our younger adults. And right now we're seeing, you know, 1 in 5 cases of colorectal cancer are in individuals under the age of 55. 1 in 3 new cases of colorectal cancer have a family history. And in this 45 to 49-year-olds, our newest patients who are eligible for cancer screening, only 1 in 5 are up to date in cancer screening. And you all know this. You know, certain communities are at higher risk, certain geographies, certain racial ethnic groups, certain poverty levels. You know, our American Indian and Alaska Native people have the highest rate of colorectal cancer in the US, and Alaska natives are the highest. Even when you break that out, there's even a more significant barrier and burden. Black individuals have the second highest rates of colorectal cancer and are more likely to be diagnosed at a later stage. And then we have some states, luckily represented on this webinar and learning collaborative, that have the highest rate of new colorectal cancer cases. So we're looking at over 150,000 individuals within the United States who are going to hear the words, "You have colorectal cancer," this year. And, over 50,000 individuals are estimated to lose their battle with colorectal cancer. So, and this to me really paints the picture of the opportunity. We have the opportunity to get patients the benefits of early detection. When we have over a 90% survival rate, a 5-year survival rate for colorectal cancer versus only a 15.6% survival rate. If it's caught in a distance and it's spread, it's not that localized colorectal cancer. And, one of the things every year I update this graph, and it's so wonderful because I started at 12%. Last year it was still 14%, and now we're seeing over 15% 5-year survival, which is just such a testament to the better treatments that are becoming more and more available. But man, we just have such an opportunity to create access to early detection and better outcomes for our patients. So almost 60% of cases are diagnosed at a late stage in the United States. And this is so of these years, 2016 to 2020, 59.1% of the cases were diagnosed at a late stage. What you're seeing here are the incidence rate, the late stage incidence rates by county. So there are definitely pockets of counties that have a higher rate of individuals being diagnosed later. And we're also seeing, there are differences in race, ethnicity when it comes to new cases, as well as, mortality rates. And, the top two are American Indian, Alaska Native, and non-Hispanic Black individuals for both incidence and mortality. Okay. Our guidelines. So since 2018, the American Cancer Society has added the earlier age range of 45, to 50. It used to start at 50. And, really focusing on a few things on here. And I know you guys know these guidelines, but really starting at 45, and making a choice on which screening is going to be right for that patient, and knowing that regular screening is critical. Those screening intervals, it's not a one and done, it's a behavior of regular screening that we're fighting to get these patients access to, and in this new behavior. And so let's keep going. Here's the clinical guideline, the published guideline, with a lot more detail on the screening and the rationale. And here's our guideline compared with the the more recent release of the U.S. Preventative Services Task Force. And very common. They really the only difference is around they have an additional flex sig every 10 years with a fit every year. There aren't a lot of people getting flex sigs for colorectal cancer screening, but it is on there.
Molly, I'm sorry to interrupt you. There is a question/comment, from Adriana Rojas. And she's saying that she's curious to know the age breakdown of the late stage incidence rate. It seems like.
Yeah, and on the slides, and I will get a link to this is from NCI and CDC's state cancer profiles, and you can look at it at least on the state level. You can look at it by age group, but I highly recommend the place that you can get the best data on to answer this question is your state cancer registry, because they look at, and even better, if you're collaborating or can collaborate with a cancer center that's in your medical neighborhood, because cancer centers are tasked with looking at their top 5 cancers and forming partnerships to do something about the rates. So I think, absolutely honing in on who is diagnosed late, but I'll make sure you get that. The link is on the slide as well. But you can dig into that data on the county level, on the state level. There's, you can look at race, ethnicity, and different age groups for late stage diagnosis. I do know that in our latest cancer facts and figures, and I didn't put that on here, individual colorectal cancer for individuals under 50 is a leading cause of cancer death. And that's new in the trends of cancer mortality. So just another reason we've got to get folks screened. We got to know their risk. We got to make sure they know if they're average risk or high risk, but then working to get them screened at 45. So obviously there are things we can change.
Yeah. Just one thing. Yeah. I'm sorry to interrupt you.
Please.
I see that people are asking for the slides since you are mentioning the slides. And if you go all the way up in the meeting chat, you will see the PDF of the slide.
I'm going to re-add it because I think, yeah.
From there.
There we go. So I re-added it, but also sometimes if you join a Zoom, you can't see what was in the chat before you got on here, but there you go. PDF of the slides are now in the chat. Please, and anybody, please raise your hand and put questions in the chat, and we'll you'll get the content one way or another. So things we can modify, things we can't modify. If there are existing polyps, the family history. Obviously we can't modify that. Important to know. And there's genetic risk factors that are very significant in putting someone at high risk for colorectal cancer. Lynch syndrome and FAP are two, and about 5% of people who develop colorectal cancer have an inherited gene mutation. So again, a personal history of, inflammatory bowel disease, aging. We want people to age. We want to create healthy people who age well. Racial and ethnic background, and having type 2 diabetes. All things that put someone at higher risk. And I was on another webinar with FQHCs, and a really innovative showing this, and someone said, what if we started with our diabetic patients in our outreach? And it was just like, yes, those patients, you're already working with them to control their diabetes. That's another UDS measure. Absolutely. Like they're at higher risk, and so we really need to make sure they're getting screened. Things we can change: diet, physical activity, alcohol use, having, maintaining excess body weight, and smoking. All of these will contribute to putting someone at a higher risk for colorectal cancer. Okay, so there are tools to assess risk. This tool is with the National Colorectal Cancer Roundtable. And these are some questions developed by the University of South Carolina. 4 easy questions to figure out if a patient is at high risk. So, okay, another poll question. Does your system have a protocol for assessing for colorectal cancer risk? Let us know. Love it. Already seeing some in the chat. if those of you who have a systematic approach could tell us a little bit about it in the chat. You know, how do you do it? Just put in the chat as we go through, because I know that there are other folks who, good, 71% say yes. So our 29% who say no, you've got colleagues and peers who have figured out some tips and tricks with incorporating risk assessment. And you can pick their brain and we can get more patients to know if they're at average risk or high risk, because that does change what they're eligible for as far as screening. So you know, here's just to keep driving home the fact that we've got to get our younger adults, you know, screened starting at age 45. We, you know, have just seen this increase in this age group. And, you know, we'll get questions around, well, why, you know, why not go down to 40 for screening? And what they found in the data is that that kind of below 45, the majority of those cancers diagnosed were related to a family history and a genetic mutation. And so that's again why if we know someone's at high risk and they're on a high risk screening protocol, they're going to get caught early based on that risk screening protocol versus, you know, the 45 for average risk. And, you know, it's almost doubled since 1990. The proportion of colorectal cancer in adults under the age of 50. And, you know, that's obviously significant. So another way we increase the positive outcomes for these younger adults is to know, and for care teams to know about the symptoms and what to listen for and ask about, and, you know, and not dismiss. So rectal bleeding, abdominal pain, change in bowel habits, weight loss, you know, and asking about this is really helpful in listening for it. And, you know, we're really moving to a place where we're not dismissing the zebras. I mean, especially with this, because the rates are going up and, you know, we need to look for the symptoms. And if someone has these symptoms, they need to go straight to colonoscopy and not have a fit kit or stool-based test. So stool-based test, visual exam, colonoscopy, or FlexSig. And we've got options in stool-based test, pros and cons for everything. I really like this tool from the Cancer Society. There are, you know, many out there, but it just helps to explain, you know, what someone, you know, to help make a choice. And, you know, myths and facts and questions for your healthcare provider. So this is a patient-facing tool to help patients. The National Colorectal Cancer Roundtable has a phenomenal resource if you are getting started with adding a stool-based screening program to your list of options or want to improve that. I highly recommend this tool. Okay, for those of you, and some of you are about to see your name on some of these slides because you're award winners, but love to know, please share with your peers, what are some key successes you've had with getting your patients to return those fit kits? So put it in you can do it in the, there's a poll that just popped up to enter your answer. What's working for you? We know it's a barrier, but we also know you all have created some solutions. Ooh, I love that. We've been mailing out instructional letters with QR codes in English and Spanish and English. Calling them, being persistent with reminders, huge.
Hey, Molly, I'm just giving participants some time to type in their answers. Just let me know when
Perfect.
to. Okay.
Yeah, go ahead and stop and we'll.
All right. Sure.
Yeah, maybe we can see some of these. I'm not able to see the results. If you're able to see the results, Fide, would you read us a few?
Yeah, of course. We have somebody that said reminder calls and texts, outreach by CHW. Oh, I can maybe, I don't know. Outreach by CHWs. We use Cologuard more than Fit Now. We have a few CHWs who make FU calls. To a small subset of patients, Cologuard providers FU texts and letters to patients as well. Auto mailing of FBO kits when due and follow-up call. We have a lot of follow-up calls as well.
Mhm.
Assessing for barriers, delivering additional kits to their homes, and offering to pick them up. Education, and again, education and follow-up soon after the appointment when the kit is given.
Wonderful. And we've got a question. Who does the follow-up calls at your clinic? So for those of you who've had success with follow-up calls, please help your peer out in the chat and let us know how you figured out how to get those done. I know one system in rural Appalachia, they actually did some PDSA cycles on how to get those calls done. And it was a nurse that was making the calls, and it ended up, she put a note on the door that said, "Do not interrupt me. I am reminding patients to return their fit kits." And then nobody interrupted her because she was, she worked in her schedule. They worked in her schedule so she could prioritize trying this intervention out. She kept getting interruptions and all the things. And like at the end of the I think she had to run like 4 PDSA cycles just to figure out the best time and process for getting those calls made. And then it only took 15 minutes in a day or whatever, whatever that was. But I just share that because it was a little tweak that made all the difference. That sign on the door made all the difference. They were having a competition for fit kit return. And so obviously no one wanted to interrupt her because they wanted to win for that. So as you're thinking about, we have it. Oh, yep. The navigator. Love it. Love it. As you're thinking about what to add and tweak, here are some of those critical components when it comes to colorectal cancer screening and, implementation in the clinical setting. So make the recommendation. Your patients knowing how important this is to you as a care team member, as a family member is critical. And asking patients about their preferences. Sometimes individuals knowing that, oh gosh, if I do the colonoscopy, it's just once every 10 years or maybe once every 5 years if they find something, versus the idea of doing something once a year, or I'm going to choose Cologuard because that's once every 3 years. Those kinds of things can help someone turn into a regular screened individual. Starting at 45, figuring out how to start at 45, being persistent with reminders. I mean, you all shared that as best, as things that are working, being persistent with the reminders, automating that as much as possible so who needs to be reminded, because calling everyone and reminding everyone isn't needed. you know, but then honing in on where are those gaps in care, who needs to be reminded and how they need to be reminded. Assessing your patient's family history, medical history, age, being able to know those things and put individuals in the different risk categories, and having those standard operating procedures and processes and policies within your FQ is incredibly helpful. Using non-clinical staff as part of your drive to increase access to early detection, and thinking about those referrals, the what happens next for everyone, whether they're getting a colonoscopy or whether they're getting a stool test, and you know, whether that's FIT or Cologuard, and then what happens next if they have a positive and do need that colonoscopy, you know, working through that process. Okay, some don'ts. Please don't use digital rectal exams. That's still happening. Like up to about 25% of primary care providers are doing a digital rectal exam to collect the specimen for a FIT kit. It's missing, this large study missed 19 out of 21 cancers. So now you have somebody walking around that thinks they don't have cancer, and they do have cancer, and they've missed the opportunity for early detection. Don't repeat a positive stool test. If it's positive, it's positive. They've got to go to colonoscopy. Don't use stool tests with individuals who are at higher risk. They need to go straight to colonoscopy. And really, you know, listening for those symptoms in your earlier age patients is really critical. And then this is a newer one. Once you have a positive stool test, get them into a colonoscopy. The outcomes are starting to decrease 90 to 120 days after that positive, you know, after a patient has tested positive with Cologuard or FIT. You know, after about that, you know, there's some of the research says 90 days, and there's some other that says 120 as far as getting them that that follow-up colonoscopy. Okay, if there isn't follow-up, our patients lost to follow-up, and it's common, but if there isn't follow-up, you might as well not have even screened that patient. Because they don't have access to early detection, and there's, you know, they're out there. All of that work that you put in to calling them, mailing them, all of those things. If you don't have processes in place to get them to that follow-up colonoscopy, or from the colonoscopy to treatment, you know, you might as well have not screened them in the first place. Okay, what strategies, another poll, what strategies are working to get your patients access to follow-up colonoscopies? Are we getting some responses?
Yep, we have a few.
Awesome.
Right. We still have like some coming in. So
great.
All right. Let me end the poll now. All right. So for One of our participants said DRVs and QI reports for follow-ups. Another strategy is finding resources for those who are uninsured. Follow-up call, letter, portal message, if the scheduling is not complete. And also use of marketing language and theory during clinical exams and reminders.
Love it.
We have another one in the chat as well. We do general text messages asking if they would like to be tested. And if they say yes, we send out a kit with a instructional letter.
Yeah, I think, one of the things that is showing up in the literature, but then also as I talk to you all and other FQ care team members, is that opportunity when you are, convincing a patient to be screened. And sometimes I know you talk to them over 10 years and finally they'll get screened. But in that, talking about the importance of the follow-up and saying, while it is rare, you might need follow-up and here's the game plan for that. Knowing that up front leads to more patients who are, who follow up. And, just that kind of prevention, that prevention part of the conversation with your patients. Okay, so what are we seeing nationally? You all know the UDS measure. There it is. If you don't, this is the 2022 measure, because the data that I have from HRSA is your 2022 data. But here are the trends. When I graph the entire UDS, all close to 1,500 FQHC systems, you can see that in 2014, right around 35%. And then here's the dip during COVID, where there was about a little over 5 percentage point decrease, and we're getting back up. But even in 2022, let's see, 1, 2, 3, we're 5 years behind. So COVID really took around, put us back about, 5 years as far as early detection for colorectal cancer. And, you see the 80% line, that's the National Colorectal Cancer Roundtable's goal, 80% in every community. And then also the Healthy People 2030, the goal set with them is 68.3%. And here are the screening rates, by state, and you can see where, we've got some, some states that have screening rates over 50%, and some who do not. Here's the rate with the numerators and the denominators, so you can see. I mean, looking at this is still incredibly impressive that in 2022, FQHCs were able to get, almost 3 million patients, screened for or up to date on colorectal cancer. Which is both shaking me up, okay? Okay, so here you're seeing what I did is I just graphed our, screening rate by state. And Alabama, I don't know if we have anybody from Alabama on, but I know we're here to help for sure. And all the way up to Maine is leading the pack. Okay, do you know your current screening rate at your system? I heard and saw some folks have some sophisticated dashboards, so I hope you're clicking yes. But right now, All right. So 75% said yes, and 25% said no. This is such a critical part of improvement, is knowing who's not screened, is knowing, and even being able to break that down and equity stratify your colorectal cancer screening rates, and looking at, is it your public housing patients who are screened or not screened? Is it, distance to one of your clinics? Is it, what is it about your unscreened patient population? So first, just knowing what the overall patient, screening rate is phenomenal. And then if you have the time and have the right friends in your IT team to then dig and say, okay, if we look at those, our patients, and you can take it by age group. Let's just take our patients who are 45 to 50 and who's not screened. And, are there some commonalities about those individuals who aren't screened? Is there something we can do specific to get them screened? It may be not. It may be that everybody needs the same protocol, but just being able to take a step back and look at who is not up to date on screening can be incredibly helpful to target your intervention and your outreach for your patients. All right. So we had, close to almost 4 million individuals who were an FQHC patient, who were eligible for colorectal cancer screening in 2022, but were not up to date. So definitely opportunity to decrease that number. I know it has. So I wanted to start this section off with highlighting, and you guys have already done it in the chat, and I know when you registered, your peers have overcome many of the barriers you all expressed in things. And so, I wanted to highlight, these are just the national colorectal cancer roundtables, 80% in every community award winners. And they just had their national webinar for March's Colorectal Cancer Awareness Month preceding this webinar. I don't know if any of you were able to join that, but the replay, it will be wonderful. And so these are just the FQHC winners. Family Health Services in South Central Idaho really worked on, patient education and outreach, barrier identification, provider recommendation, navigation to colonoscopy. Once there was something positive, they took that specific patient population and linked them with the navigator. And this innovative program that fundraises at least $25,000 each year for discounted follow-up colonoscopies. And then, in 2023, there was a great partnership with UT Austin and an FQHC community care health centers that really looked at those patients who, they did a mailed kit and really navigating those with a positive. And Esperanza, and I see somebody from Esperanza on today, so award-winning in the house with us. And they credited many things, but one was their data dashboard, and like knowing which of the patients had screening rates. There's obviously a competition and there were goals that were set. And so thinking about, prepaid mailers, and, really looking at that. Oh, I like the sheer volume of overdue patients. Yeah. And I think, Adriana, taking a look at that and figuring out like what's your low-hanging fruit in the overdue patients, and not like breaking it down. I've seen a lot of success with that because it is overwhelming and no, you can't do it. I mean, no one should do it, but figuring out like, can we focus on our diabetic patients? Can we focus on, what is the subset of those overdue patients that might be less resource intensive to do outreach with, to flag? In 2020, one of the things that I wanted to highlight about this award winner is that that screening eligible patients received a recommendation at all health center visits, even dental, even vision, to avoid those missed opportunities. I thought that was, what a great team effort to get patients screened. So another resource that I highly recommend use, revisit, is the steps for increasing colorectal cancer screening rates and manual for primary care practices. Lots of examples from other FQHCs, including NOLA, which is on the call today. And here's the little promo video.
Colorectal cancer screening saves lives. Together, we can reach colorectal cancer screening rates of 80% in every community. You can increase screening rates in your practice with the new NCCRT Steps Guide. The new guide contains expert-endorsed strategies, screening options, templates, tools, and more. Major guidelines recommend starting colorectal cancer screening at age 45. Timely screening is more important than ever. The Steps Guide is your one-stop shop for strategies to increase colorectal cancer screening in your practice. Get started now at nccrt.org/Steps Guide.
So this guide, it has the background section on the importance of colorectal cancer screening, and it goes through steps, which you'll see shortly. There are 10 case studies, many from federally qualified health centers, and there are some great, tools that they're with links to them. So making a plan, identifying a team, getting your patients screened, and coordinating that care. We've got communication and continuous quality improvement that's kind of holding up all of the steps, and determining your baseline rate. So when you look at step one reason I asked you the question around, do you know your screening rates? Determining the baseline rate, and that baseline rate could be very different things. It could be, we're going to look at the baseline rate for only our public housing patients. We're going to look at the baseline rate for only our 45 to 50-year-olds, and we're going to really hone in on that. And so, looking at who needs, breaking that down and improving the accuracy of that baseline rate, and figuring out your own need for colonoscopy. The National Colorectal Cancer Roundtable has a colonoscopy calculator, which was really helpful just to figure out, okay, around how many colonoscopies are we going to need for our patients. So this is the most recent tool out of the National Colorectal Cancer Roundtable. It's the Lead Time Messaging Guidebook. There's an amazing webinar that the replay is on this site, and it really goes into, here are the key takeaways, really around this early age and what we need to do. And that, there's knowledge gaps for sure. There are people who, just really looking at, that people know this information, but they want to hear it from a healthcare provider. And they're motivated to be screened when recommended by someone in healthcare. Like, knowing that, I want you all to know that. I want you to spread that message to your counterparts within your system of how important it is that recommendation is coming from you. And so the intent of this guidebook, share best practices, why you all are part of a learning collaborative in the first place. I know And how the intent is to encourage people, starting in their 20s, to discuss family cancer history, and knowing that, so we know which, if they need to go in the high risk protocol or the average risk screening protocol. Encouraging people to talk with their healthcare provider, and really motivating individuals to have regular screening and on-time screening behavior. This is this guidebook came out in 2022 and is just really helpful. It's a focus on Black and African American people, and it goes into, with the market research that they did on unscreened individuals, why individuals didn't want to be screened, and putting those into buckets. So a recommendation from a clinician is the most predictive factor for a patient initiating and completing the cancer screening process. So I know some of you, because your ACS team members have shared some of the letters you all are sending, and the text messages, the automated calls, like even having the nurse be the person, or the doc be the person that's recording and saying, I see, that you haven't been screened. I want you to go get screened, call our office. Even those little tweaks to make sure that that patient knows that their care team wants them to get screened is critical. So this is just some of the data to back that up. Looking at significantly less likely to be screened if they're not, even with everything that goes on and the marketing, and Cologuard has a golf tournament now. I mean, all of this, there's marketing from everywhere. Still, individuals are less likely to be screened if their care team didn't recommend it. So I just wanted to leave you with that. And here's my contact information. And for those of you who, if you're not already connected with your American Cancer Society associate director, please reach out to me and I'll get you connected. I noticed some of your names on here because of American Cancer Society work, but know that we are here to help link you with best practices and overcome some of the barriers.
Excellent. Thank you so much, Molly. This has been an outstanding presentation, and we went over the screening rates and the screening recommendations and some best practices. So this is a really great session, and thank you again for your collaboration and your expertise. Right now, we would like to do a Q&A. If you have any questions for Molly, please, you can either type your question in the chat box or the Q&A box, or if you want to ask the question verbally, we can also unmute your line. So please, this is the opportunity for you to ask any questions and get feedback from Molly. And I see a hand icon. Fide, can you unmute the line?
Hi, my name is Darlene Burton from Esperanza Health Center. I'm the colorectal cancer navigator here. My question would be, if someone has a positive FIT test and they do not want to do a colonoscopy, how would you navigate that?
I mean, that's the intervention. That's the next step in the intervention, whether it was surgery for something. I mean, I think that all that motivational interviewing that I know you already do, that's the strategy. That's the patient to double down on and figure out, okay, do I need to get a doc? Do I need to get them to bring their wife in? You know, like pulling all the tricks out for that patient, because there's not, you know, repeating a fit is not, you know, it's not helpful. I mean, even if you redid a fit or you did Cologuard, and it came back negative, that doesn't mean that they're not you know, positive. Dr. Lombardi,
Yeah, can I pop in just for just a moment?
please.
So who is informing the patient of the positive result? And this is a question for who asked the question.
So the doctor is informing the patient of a positive fit test. But it comes up on my screen when calling patients within our ecosystem. And there are patients who I know for a fact need a colonoscopy.
And they
But
have
for what
and they have a positive Cologuard
fit? Yes.
positive fit. So
Yes.
this is a conversation that needs to happen between the physician and the patient, and that's really the only place where that conversation can happen. Because when you have when you have a positive result, it might be cancer.
Right.
So
It has happened between the clinician and the patient, but how do you navigate someone that's so fearful to know? Because my thing is better to know than not to know. And just because you don't know it's there does not mean it's not there. But some patients are so fearful of the C word that they will forgo a treatment that can have the potential to save their lives. So I just wanted to know, is there a special way you navigate trying to convince a person with a positive fit test to do a colonoscopy when they're so fearful of what the colonoscopy will say?
Yeah, you know, I've been in that situation many, many times. And I think the important thing to realize is that every one of those is going to be very different. It's going to depend on the patient. It's going to depend on their cultural background. It's going to depend on the difference between your and their cultural background, or differences between you and the patient. But people understand things in different ways, and the balance of how you're using positive marketing, how you're presenting the information to the patient that might scare them, really depends on the individual patient interview. But like, there are certain responsibilities in these circumstances of things that need to happen. And those are responsibilities because the data tells us that there are good ways to get that ball moving. I have had uncomfortable times with patients where I know they have a positive result, or I know they have something that more generally needs to be followed up on, and that following up has not happened. And that could be a life or death situation. This is by no means the only example in medicine of this sort of situation. And sometimes those are longitudinal relationships that lead to that. And I can give you the example of my own father, who didn't listen to his doctor's son and get a colonoscopy for 5 or 6 years. This was my father. And I've had patients that it has taken years for them to even consider getting the test, because for many people, it's a very strange and unusual thing that an actual colonoscopy does. It takes a while to get them to warm up to that. So what I would say is, because of those responsibilities and because of that sort of ecosystem behind the clinical examination, the important thing is make sure your providers, everyone, is asking about this, and make sure the conversations are happening when that happens. And sometimes it's really just an issue of the right person talking to the right person about it, or it just everything in everyone's life kind of aligning the right way. But sometimes you need to do this multiple times before the person will actually get the result. So just make sure those conversations are happening. And if you're seeing, if the physician or the person who's in charge is having these conversations and they're not having any luck, just ask them. Say, hey, how are those conversations looking? You may be able to provide some perspective that can make a big difference for a patient.
There is a really good comment as well, and this is a comment that I was going to make as well, and is sometimes you need to use your behavioral health team. As a provider, if you are a family practitioner, probably you will have to rely on your behavioral health team to try to convince the patient. But here is never give up on any patient. Let's try to help them and making sure that they receive the adequate follow-up, which in this case is the colonoscopy.
Thank you all for that information.
Thank you for the question. And let's see whether we have any other question or comment here.
We have another question, Dr. Leon.
Okay.
And this question says, screenings are the first step. Once a positive screening, are there any creative ways to have the colonoscopy paid for?
I'll take it if there's no takers for that. And it's not going to be a very satisfying answer. But the answer is it really depends on where you're practicing from and what kind of insurance this patient has. So are they insured? Are they not insured? Do they make criteria for Medicaid or social safety net insurance? That's going to affect the question here as well. Certain states have programs. So what I would say is be aware of the ecosystem and the resources in your area. Is that person eligible for this being covered by a social safety net insurance in your state? And that's going to depend on your state and local government. Are there state or local programs that are available as well? This is why it's good to have a good staff of social support and community health workers who can work individually with patients and identify those programs that may provide support. So the answer is really going to depend on where you're from and what that specific ecosystem is. And I guess the recommendation I could make is really know who pays and who doesn't there. And if there are state, federal, local programs that can fill in any gaps that you have.
And I didn't see them on the list. But I know Beaufort, Jasper, Hampton Community Health Services did register, and so maybe they're going to come. They were part of the American Cancer Society's Links to Care pilot. And in that pilot, that was the goal, was to create a community solution for follow-up colonoscopies. And they worked with individual gastro practices that ended up merging with the hospital, like happens many places now. And they used the calculator and they said, okay, if we increase our fit rates by this much, that means we're going to need this many colonoscopies for, and they broke it down by insurance status. So to Dr. Lombardi's point, they were able to say, they did two things. One, they were able to say, we're going to be sending you X number of insured patients, and we need you to help us create care pathways for X number of patients. They did that while also working with the hospital, who pulled their ER admission records on individuals who came in, uninsured individuals who came in with bleeding and needed colorectal cancer treatment. And it was a no-brainer for the dollars and cents. And, now there's a regular stream of uninsured, patients who don't fall into, there's no other option, are able to get the follow-up colonoscopy through their, through their pathway. And so I can't agree more, knowing what is available, consistently checking on that, leveraging your insured patients, and, figuring out, using that colonoscopy calculator to figure out, you will be surprised. It might be 2 a month that you need, that, if you really get things going, 2 a month, and then proactively figuring out, what you can kind of negotiate with that. Also, they are more willing to say yes or no based on the history of prep from your patients. So if your practice is sending patients to a gastroenterologist insured, whatever insurance they have, and they're not showing up prepped, you're not gonna, it's gonna be a harder hill to climb. But if you put in your navigation and process so that, everyone is showing up to the appointment and showing up prepped, you're gonna be able to find creative solutions to your uninsured patients.
The biggest issue is that many patients going to the health centers are uninsured. So I think that is the main concern for some providers to refer patients who need a colonoscopy. And Molly, correct me if I'm wrong, but one of the awardees worked with community organizations to raise funds, right? For
this year's winner
for colonoscopies.
Yeah.
So I think that is a really good promising practice, to work with your community and get some funds for those people who cannot pay or who cannot afford a colonoscopy. So if you have any arrangements with a hospital system or a private clinics, you can refer these patients. Any other questions, Fide? We are over time.
Nope.
All right, so thank you so
questions.
much, everyone. We have our next session on the 20th. So thank you again for participating. Thank you, Molly, for being with us. And please complete the survey after this webinar is over. And if you have any additional questions, you see the contact information of all of the staff members. And if you have a question for Molly, the contact information is in the slide deck that she provided. And otherwise, you can contact us and we can get in touch with her. So thank you so much and happy afternoon.
Goodbye, everyone.
Bye.